Vamos ahora pues con la siguiente conferencia que será pregrabada. La siguiente conferencia se llama Autoanticuerpos en miopatías inflamatorias idiopáticas, cómo vamos en pediatría. Esta conferencia nos la da la doctora Hanna. La doctora tiene especial énfasis de investigación en dermatomiositis y en miopatías inflamatorias en general. Ella es investigadora clínica, asistente y jefa de la Unidad de Estudios Translacionales y Terapéuticos en Miositis Juvenil en Bethesda, Maryland, y tienen específica énfasis en el estudio de nuevas terapéuticas que puedan apoyar el manejo de las miopatías inflamatorias, buscando también pues todo lo que hay respecto a la génesis de la enfermedad. Específicamente han estudiado el efecto de la JAK quinasa en esta y pues buscando nuevas terapias al respecto. Entonces pues la doctora tiene varios premios nacionales e internacionales en su país respecto a investigaciones que se han enfocado específicamente en este tópico.
Hi, I'm Hanna Kim. I'd like to thank the organizers for the opportunity to talk with you about autoantibodies in juvenile idiopathic inflammatory myopathies. Here are my disclosures. The objectives of this talk are to review myositis-specific autoantibodies, or MSA, and myositis-associated autoantibodies, MAA. I'll discuss what the clinical associations are with each of these and highlight what to consider when approaching myositis autoantibody testing. Juvenile myositis is a broad group. As you've heard some about, it's clinically heterogeneous and there's a lot of variability. It is characterized by proximal or close to the center of the body, symmetric, same on the right and left side of the body, weakness with inflammation of the muscles. And this includes juvenile polymyositis or JPM when there's no skin involvement. The majority of juvenile myositis, however, does include skin involvement, and it's called juvenile dermatomyositis or JDM. This is 90% or more of juvenile myositis. Gauthron's papules are one of the characteristic findings. These are erythematous or red on extensor surfaces like the knuckles, elbows, and knees, and heliotrope rash, which is the purplish or reddish around the eyes. This is sometimes associated with swelling. This person on the right also has a malar rash. 2/3 or the majority of patients have a chronic or polycyclic disease course, meaning they have recurrent flare of disease. And myositis autoantibodies can further subgroup this broader group of juvenile myositis by clinical and pathologic features. Myositis autoantibodies are present in the majority of juvenile myositis patients. Up to 80% have a positive antinuclear antibody or ANA. Myositis-specific autoantibodies or MSAs are present only in patients with juvenile myositis and are present in 70% of juvenile myositis patients. Myositis-associated autoantibodies, or MAA, are present in about 20% of juvenile myositis patients, but they are not specific or exclusive to juvenile myositis and may also be present in other autoimmune or connective tissue diseases like arthritis or scleroderma. So I'll next go through some of the myositis-specific autoantibodies in order of their frequency. So anti-TIF1 or P150/140 is the myositis-specific autoantibody that's most frequent. I included data from multiple cohorts from around the world that had at least 20 in their reports. So in the North American, United Kingdom, or UK and German cohorts, anti-TIF1 was present in 13 to 35% of juvenile myositis. In Japanese cohorts, it was present in 16 to 43%. This includes patients with juvenile dermatomyositis, meaning with skin rash, juvenile connective tissue disease myositis or overlap myositis, and juvenile clinically amyopathic dermatomyositis, meaning they have the skin features, but the muscle features are very subtle or hard to detect. In the North American group, they reported that the majority of myositis patients with anti-TIF1 were white. And in general, anti-TIF1 is not associated with cancer in children or juvenile myositis. Anti-TIF1 is associated with cancer for adult myositis, but in general, for all of juvenile myositis, it is not associated with cancer. What else can we see with anti-TIF1? So it is associated with a lot of skin findings. There are widespread photosensitive skin rashes, meaning there are rashes in sun-exposed areas that are worsened with sunlight or UV light exposure. Some examples of this are the V-sign rash or wrath in the areas that would be exposed by a V-neck shirt, and a shawl sign rash, which is the redness around the shoulders or in the shape of a shawl. There are also rashes on the face, and there's a particular type of rash called linear extensor erythema, which are lines around extensor surfaces that you can see on this hand here. There also may be scalp rash. Anti-TIF1 is also associated with erythroderma, which is a red rash that covers the entire body, swelling or edema, and lipodystrophy or loss of fat in certain areas, and ulcers of the skin. There can be variable amounts of weakness, and it's associated with that chronic or polycyclic disease course. Anti-NXP2 or anti-MJ is the next most common myositis-specific antibody, or MSA. This is in 15 to 39% of North American or European cohorts and 12 to 26% of Japanese cohorts. It can be seen with juvenile dermatomyositis with the skin rashes, with juvenile polymyositis without the skin rashes, and overlap disease, the connective tissue myositis. What we see with anti-NXP2 is a very prominent weakness. This can involve both proximal muscles and distal muscles, so it involves more muscles. There's also more weakness in the muscles that are involved. There's more inflammation, higher muscle enzymes, and more abnormal muscle biopsies. This is an example muscle biopsy. It's showing perifascicular atrophy, meaning the muscle fibers are little circles around the edge of this fascicle with these lighter whitish borders are smaller than these more central muscle fibers. Perifascicular atrophy can be seen in juvenile dermatomyositis in general, though it's not specific to anti-NXP2. Oops. Myalgia or muscle pain can be seen with anti-NXP2. And it's notable because many patients, and probably the majority of patients with juvenile myositis, do not have pain with their myositis. It's an inflammation that's associated with weakness, but without pain. But pain is associated with anti-NXP2. There can be wasting of the muscle or atrophy, joint contractures, or a loss of range of motion of joints and stiffness. There also may be more frequent edema or swelling, trouble with swallowing or dysphagia, and changes in the vessels in the gastrointestinal tract, which is where the arrow is pointing. This is not a common finding, but it can be very severe. It can lead to trouble absorbing food and nutrients, ischemia, loss of circulation, and bowel perforation or bowel loss in the most extreme form. Calcinosis is also noted to be more common with anti-NXP2, up to 43% in the United Kingdom cohorts. There is more frequent hospitalization with anti-NXP2, which likely reflects the more severe disease activity with anti-NXP2. It has a younger disease onset, and there's less remission at 2 years, which frequently means more medication is needed for a longer period of time. Anti-MDA5 is the next most common myositis-specific autoantibody group. This is present in 3 to 8% of North American and European cohorts. And this is the MSA group with the most difference between different geographic locations in the world, because it's much more frequent in Japan or other East Asian nations at 24 to 39% frequency amongst juvenile myositis. It is seen in juvenile dermatomyositis and also clinically amyopathic dermatomyositis. So what do we see with anti-MDA5? As we heard some about, it's associated with less muscle disease. It has arthritis and arthralgia that's highlighted by these joints or bones being circled. So joint inflammation and joint pain. It has systemic features like fever and weight loss, and also cutaneous ulcerations. Interstitial lung disease, or ILD, is a frequent feature of anti-MDA5. It's shown in the CT also. It's between 19% and 35% of those with anti-MDA5, as you can see from the different geographic locations. And there also has been a particular form of interstitial lung disease called rapidly progressive, or RP-ILD, meaning that there's an increase in symptoms or a an obvious progression of the features by imaging within 3 months, amongst other definitions. It's not extremely common, but it is more common in the Japanese cohort. Up to 19% of the anti-MDA5 patients had this, and there is increased mortality with this rapidly progressive interstitial lung disease, between 50 and 70%. There have been some studies in Japan looking at what can predict this very severe feature, rapidly progressive interstitial lung disease, and they've seen that when they have a higher titer or measurement of this anti-MDA5 antibody, high ferritin, IL-18, or KL6, that it is more associated with rapidly progressive interstitial lung disease. Antisynthetase is the next myocyte-specific antibody that I'll discuss. You may be most familiar with anti-Jo1, which is one of the antisynthetase autoantibodies. In general of note, this is the most common autoantibody in adult myositis, but it's much less common amongst kids or juveniles. And there are many other amino acyl tRNA synthetases that are part of this group. In North America and European cohorts, it's between 2 to 5% of juvenile myositis, whereas in Japan, it's between 0 to 4%. This includes in juvenile dermatomyositis with skin rashes, juvenile polymyositis without skin rash, and the overlap myositis. What do we see with antisynthetase myositis? There is variable weakness. It's noted to have less weakness in some. There is more interstitial lung disease shown with the lungs. There is more arthritis or joint inflammation shown by highlighting these bone joints. And mechanics hands is a rash that can be seen. This is more commonly seen in adults, but it is particular to antisynthetase. It's a roughness or scaliness on the lateral aspects or the sides of the fingers. You can also see fever and Raynaud's phenomenon seen in this photo. And there's an older age of onset with antisynthetase. Anti-MI2 is between 3 to 4% of juvenile myositis in North American and European cohorts and 0 to 4% of Japanese cohorts. It's seen with juvenile dermatomyositis and the overlap myositis. In North American cohorts, it's described to be more common in Hispanics. And what do we see with anti-MI2? There is, in general, thought to be a pretty typical or classic presentation of juvenile dermatomyositis. The weakness can be pretty prominent. There will be higher muscle enzymes, and amongst the types of muscle biopsies that can be seen with juvenile myositis, anti-MI2 can be some of the most severe, similar to anti-NXP2 in some cases. They can have dysphagia, which relates to the muscles being weak with swallowing, and also edema or swelling. As far as skin rashes, they tend to have the typical or characteristic skin rashes seen here, the rashes on the face and the Gauthron's papules in typical locations, and they have less interstitial lung disease. But unique to anti-MI2 and a good prognosis is associated with this because it is generally responsive to standard therapy. Next, anti-SRP is relatively rare. It's in 1 to 2% of North American and United Kingdom or UK cohorts, and is one of the MSAs or myositis-specific autoantibodies that is part of this immune-mediated necrotizing myopathy, or IMNM. This is associated with necrosis or cell death on biopsy, and on muscle biopsy, there is not much inflammation, which is unique amongst the juvenile myositis population. It can be seen in what was been traditionally called juvenile polymyositis, and in North American cohorts, it is majority Black. What do we see with this? It's generally very severe at onset, and it's associated with severe weakness. So a lot of muscles involved, both the muscles close to the core and distal to the core, proximal and distal muscles. They typically have a history of falling because of the significant weakness. There are very high muscle enzymes associated with this. They're frequently so weak that they need or require a use of a wheelchair. The muscles can be wasted away or atrophied that might be able to be seen when you examine them or on imaging like MRI. And they also have pain or myalgia associated with their weakness. They typically do not have any skin rash, and there is more frequent involvement of the heart or cardiac muscle. They can have Raynaud's phenomenon. And generally, there is frequent hospitalization with this MSA group, anti-SRP. They have a chronic disease course, and unfortunately, there is a poor response to treatment. Also of note, this category of immune-mediated necrotizing myopathy, or IMNM, has a lot of features that may overlap with this muscular dystrophy, particularly limb-girdle muscular dystrophy. So it's something to keep in mind. The next MSA group is anti-HMGCR, which is the second myositis-specific autoantibody that's in this same group of immune-mediated necrotizing myopathy. This is present in 1% of North American and United Kingdom juvenile myositis cohorts. You may have heard of this as it was first described in adults and associated with adults that had previously taken statins like lovastatin. It is not associated with statin exposure in kids, but it is still observed in juvenile myositis. What clinical features are seen with this? It has a lot of similarity or overlap with anti-SRP that we just talked about. It is very severe at onset and there's severe weakness associated with it. It involves a lot of muscle, a lot of symptoms related to weakness such as falling, muscle atrophy, high muscle enzymes, frequent wheelchair use, and pain in the muscles or myalgia. They also have some other features. There's pain in the joints, arthralgias. You can have loss of range of motion or joint contractures, dysphagia or difficulty swallowing, pointed out with this arrow, and weight loss. There are frequent hospitalizations as, again, this is a severe, it usually has severe disease activity, and there's a chronic or polycyclic disease course, and unfortunately also has poor response to treatment. Also similar to anti-SRP, because of these overall features in the immune-mediated necrotizing myopathy, it overlaps with limb-girdle muscular dystrophy as well. So next I'll be talking about the key myositis-associated autoantibodies in juvenile myositis. The first one I'll mention is PMSEL. The frequency of this is variable, more frequent in overlap syndromes, but it can be seen in both overlap myositis and juvenile dermatomyositis. It's associated with a myositis scleroderma overlap, as you might expect. The myositis is less severe and there is more frequent arthritis or inflammation in the joints. There's Raynaud's phenomenon, interstitial lung disease, and calcinosis, which are associated with this myositis-associated autoantibody, which may not be surprising because those are features also seen in scleroderma. URNP is the next myositis-associated autoantibody I'll mention. It also has a variable frequency, more commonly seen in overlap syndromes. This is seen in juvenile polymyositis without the typical skin rashes and in overlap myositis. This is associated with arthritis, sclerodactyly, and Raynaud's phenomenon. And when it is seen with the overlap myositis, it may be associated with interstitial lung disease. Next, anti-NT5C1A has a variable frequency between 0 and 27%. It's seen with juvenile dermatomyositis, overlap myositis, and juvenile polymyositis. You may have heard of this in adults because it was first described as primarily being associated with inclusion body myositis, a particular type of myositis seen only in adults. It's not seen in kids. But in general, this myositis-associated autoantibody is associated with pulmonary symptoms, at diagnosis, more frequent hospitalizations, and more required medications. So in general, a more severe disease course. Next, Rho52, which is present in about 15% of juvenile myositis. It's seen in overlap myositis, juvenile dermatomyositis, and juvenile polymyositis. It's more frequently seen with anti-synthetase and anti-MDA5 myositis-specific autoantibodies. And it is associated with interstitial lung disease, a chronic disease course, and requiring more medications. So this is also another myositis-associated antibody associated with a more severe disease course. So next, I wanted to review briefly what to think about when you're considering when to test for myositis-specific autoantibodies. We recommend testing for myositis-specific autoantibodies at initial workup. So when a patient is presenting with their initial juvenile myositis features and you're finalizing or trying to confirm the diagnosis, this testing will help confirm the diagnosis and also will give you more information about defining the specific clinical subtype within juvenile myositis. And even for those that have a juvenile myositis diagnosis that is well established, if myositis-specific autoantibody testing has not yet been done, it still is helpful to help define the clinical subtypes and all the details like we've reviewed. That includes what features are associated and what sort of prognosis, disease course is expected, and what type of treatment response they may have. There are other individuals with less clear diagnosis, which they may have overlap syndrome features, or they may have other diagnoses that are more likely, and juvenile myositis is less high on the differential. But doing this testing may still clarify the diagnosis. In these sort of cases, it's best done in the context of other testing, including an anti-nuclear antibody, myositis-associated antibodies, ENA antibody testing, and other appropriate evaluation. For some specific examples, isolated arthritis that is not rheumatoid factor or CCP positive or seronegative, you could consider testing for anti-synthetase or anti-MDA5, as these are both myositis types where the myositis may not be prominent, but it is associated with arthritis. And it's a similar case if with interstitial lung disease of unknown cause, as interstitial lung disease is associated with both of those. And lastly, if there's a limb girdle muscular dystrophy type of disease, then we recommend considering necrotizing myopathy antibodies that we discussed, anti-SRP and anti-HMGCR. And finally, briefly about the testing itself, there are different methods of testing. Immunoprecipitation as a panel is the reference or gold standard method. There is a long turnaround time for this, often several months. It is quite expensive and requires specialist expertise, which limits how many centers there are. There are less than 10 in the world and only 1 in the US. There are commercial panels which are widely available, such as dot plot and line blot, which provide faster results, and there's no need for specialist expertise. And ELISAs, which do 1 autoantibody at a time and can be highly sensitive. Typically, people begin with commercial panels, which allow testing for multiple myositis autoantibodies at once. But when compared with immunoprecipitation or that gold standard or reference standard testing, some tests have less sensitivity, resulting in false negatives, or less specificity, resulting in false positives. So it's important to know what testing method is used when you order this testing locally. And if a commercial panel is done and there's only a weekly positive result, or the results are negative, or if you feel like that result doesn't match up with the patient that you see, follow-up testing may be indicated and should be considered with immunoprecipitation or alternative method to get more accurate results. So in conclusion, myositis-specific autoantibodies are very helpful to help not only confirm diagnosis, but define clinical subtypes within juvenile myositis, and they can tell you more about what to expect with juvenile myositis, the disease course, and how to help manage the disease optimally. Myositis-associated autoantibodies also can be helpful, particularly with overlap myositis, and may help define disease severity or some associated features such as interstitial lung disease. And finally, both myositis-specific and myositis-associated autoantibodies have variable specificity and sensitivity in testing based on the methodology. So you should be aware of the testing approach that's being used at your local labs, as follow-up testing may be needed. Thank you very much for your attention, and I'm happy to take questions at the end.